Anyway, looks like I'm going to be giving this presentation to you and this nice gentleman in the back.
Yesterday I was in another reading that happened, but it was a switch up in the schedules too. Where they all of a sudden that was all about something.
Yeah. What is your name?
Jeremy.
Jeremy. I'm Nisha.
Nisha, nice to meet you.
Likewise. And you are?
I'm Red. Nice to meet you.
What is it? Brandon. All right.
Mm-hmm.
All right. Tell me one more time.
Jeremy.
That's what I thought. I'm working on my recall.
Sure.
Recall.
That's what. It's great. You follow.
All right, guys, it's 10 o'clock. Brandon, are you ready?
I'm ready.
Jeremy, I'm ready. All right. Well, we're just going to go ahead and get started. So, hello and welcome to Cannabis and Public Health. My name is Nishi Whiteley. I'm the COO of Credo Science, and I am excited to talk to you today about cannabis and public health. This is an enormous topic, and I have to give you a fair warning that I'm feeling a little salty today. So I'm going to go super fast because we have a lot of information to cover. And sadly, we're not going to be able to get to everything that I'd like to discuss about this topic because it is indeed an enormous topic. So I want to share my conflicts of interest as the COO of Credo Science. I want to share with you, good morning, Andrea, come on in. We have a patent application that has been filed with the USPTO for the technology that assesses if an individual is genetically predisposed to CHS, which we'll be talking about in this presentation. We also have a commercial relationship with MM411 to deliver medical cannabis education. I also have licensed a formula for the treatment of ALS to a Canadian company, Canerda, to develop this through the FDA drug development route for botanicals. And then I also serve as the manager of communications for Andira Pharmaceuticals based in Vancouver. This is a fascinating company developing cannabis-based pharmaceuticals in the area of oncology and topical antibiotics and anti-infectives. So what we're going to cover today is our education needs for us to be able to increase public safety, labeling, quality standards, and real but uncommon risks, including cannabinoid hyperemesis syndrome, cannabis-induced psychosis, and cannabis use disorder. And one very common thread that you will hear throughout my presentation is the need for us to shift from a substance abuse perspective to one of education and consumer safety. Alrighty, so moving right along, I want to point out that Texas does have, just like the rest of the country, a robust cannabis market. And as you see here, flower and pre-rolls represent 50% of the revenue in this market. Notice vapes are 17%. The reason I'm sharing this with you is we are having a conversation right now about outlawing flower and smokable products. I do not think that is the right thing for us to do. And I want to share with you, these are slides, by the way, from Dr. Robin Goldstein. He is the director of Cannabis Economics Group at the University of California, Davis. He's been a fantastic supporter of cannabis advocacy here in Texas. Hey, good morning. Come on in. And he has done some fascinating analysis that show here on the far left, you see this pie chart is showing that if we go with only foods and beverages permitted in our market, that 70% of products will be purchased in the traditional or the black market. I believe that that is an unnecessary risk for this market, and that drastically reduces public safety and causes unnecessary harm. So if you go all the way over to this side, you can see that if we're allowing foods, beverages, flour, and vapes, only 10% of sales are going to be in the traditional or the black market. And I think that this is a very important point for people to remember. We have a legislative body that is trying to regulate cannabis from a substance abuse perspective and from the perspective of, frankly, moral judgment. And that is not serving Texans at all. So let's take a quick look at health in America. Frankly, it sucks. We are not healthy people. We have terrible diets. We're not getting enough exercise. And so the net result of that is that we have an estimated 129 million people in this country that have one major chronic disease: heart disease, cancer, diabetes, obesity, hypertension. We have, it says here, 42% of Americans have 2 chronic illnesses, and 12% have at least 5. That's terrible. We can do better than that. 5 of the top leading causes of death in the United States are preventable. And these trends aren't going down. They are going up. We are becoming increasingly less healthy. About 90% of the annual $4.1 trillion of healthcare expenditures are attributed to managing these chronic illnesses. So here it is in a visual. We're not healthy people. And why are people coming to the cannabis space? Well, it's because they're looking for relief, and they have found it safely in cannabis products, medical products, as well as just over-the-counter products. I'm going to argue that all cannabis is really medical in one form or another. People are trying to feel better in different ways. So why does cannabis work? Well, the answer is the endocannabinoid system, or the ECS. It regulates, modulates, or plays a role in every major biological function in the human body. So when life wears us down, we're experiencing stress of some sort, whether that is through illness, injury, lifestyle, or traumatic situations, or just general life stress or lifestyle. Our endocannabinoid system is what is tasked with bringing us back into a state of balance or homeostasis. So this system was discovered about 30 years ago, and it's just like our circulatory system, nervous system. But the neat thing about it, well, there are so many neat things about it, is that it is involved in every other system. It's regulating pain control, mood, immune function, newborn suckling, appetite, temperature regulation, memory, inflammation, neuroprotection, and reward mechanisms. So we happen to have components in our bodies that mimic chemical components in the cannabis plant that regulate all these things you see here on this slide. So what are these kids doing? Well, they're having fun and they're spinning. They're trying to alter their consciousness, even though they don't know that. They're spinning because it feels good and they like that experience of, woo, what is this? They're feeling floaty. So the desire for humans to experience an altered state of consciousness is part of our physiology. This is a natural thing. And so we are creating these unnecessary risks trying to legislate people who want to feel better. And that is simply not productive. So over the last couple of years, we have seen a stratospheric rise in the use of cannabis consumption. And when we look at that through the lens of, okay, why, we go back to the previous slide, is because we're not healthy. And people want to get healthy. They want to live better. And so what we see here is that approximately 15% of Americans are regular cannabis users. I have seen statistics, and you may see them in some of these slides, that up to 19, maybe 20% of Americans, adults, are using cannabis. So what is driving health trends? Well, as we said earlier, people want to feel better, and they are finding that in cannabis. We have about 50% of consumers. Good morning, Amy. 50% of consumers are women, and people aren't necessarily going for the highest potency product. And when we look at consumer satisfaction, the highest satisfaction ratings are actually in the low to mid-range THC level products, not in the super high THC products. Consumers are becoming more educated, and so they're wanting to understand what is in the product. They have more knowledge about the potential effects that they might get from cannabis, so they're more informed. They know, I want better sleep. I want less pain. I want to be relaxed and be nice to my kids instead of biting their head off. So we're more clear now than we've ever been about how these products can benefit us. Cannabis is displacing alcohol. You see it in our 18 to 25 population. They much prefer a cannabis beverage than they do an alcohol beverage. And we see it time and time again when people start using cannabis, their desire for alcohol slowly starts to decrease. People also are choosing cannabis because they don't feel bad the next day. And then another important point is that 76% of consumers surveyed said that they often make their buying choices based on what the bud tender or the person at the point of sale is telling them. So that brings us to education. And now that we've established that we have multi-millions of people who want to use this product, the most important way, in my opinion, to improve public health and safety is to ensure that people are educated at every single point in the supply chain. So whose responsibility is that to educate people? Well, it's the consumer's responsibility to educate themselves. And because we have had so much misinformation, I'd like to advocate for the fact that I think that government should fund, through some of the revenue generated from taxes and fees, should fund a basic public education campaign, but not following the footsteps of what has been done before them, because all of these government-sponsored websites are coming from a highly judgmental perspective of shame and fear and substance abuse. That serves no one. People then automatically start to distrust what is there, and they go other places and often don't get access to the quality of information that they should. So what is needed? Simple, straightforward, easy to understand information that has a balanced perspective, not something that is singing the praises of cannabis and ignores the potential risks, but information that is just data. Not propaganda. All right, so I wanted to share this slide with you because this comes from the Centers for Disease Control. These are the facts that they share on their website. Just wanted to kind of back up what I was saying about how government websites often approach this from such a negative point of view. So they say that 19% of Americans use cannabis at least once in 2021. So these are fairly old statistics. This stuff doesn't get reported every year. They also estimate that 3 in 10 people who utilize cannabis regularly have cannabis use disorder. I want you to remember that number because we're going to circle back to cannabis use disorder a little later in the presentation. They also say that the risk of developing cannabis use disorder is even greater for people who begin use before age 18. And while there is interesting science about that, I would argue that we're not asking the right question, because who is using cannabis before the age of 18? If they're 12 to 15 in age, are they using cannabis because their home life is unstable, because they don't have enough food, because maybe they don't have a place to sleep at night? There are a lot of reasons that kids are going to use cannabis before they become an adult. And so I feel like so many of these statistics deserve a much deeper unpacking than what we're seeing here on this website.
Well, okay.
So I'm not going to go through all of these, but I did want to point out that there are only 2 of these facts that have more than 1 citation on them. And a large number of these citations that you see here are all written from the substance abuse perspective. So what would happen to these statistics if we looked at them through a more objective lens? All right, so what does the public need to know? I'll start with dosing and titration. It's important to start low and go slow. I loved yesterday in the panel when Chelsea Spencer kept saying, we have not had a single adverse event in teacup or with her teacup clients. And the reason for that is because people are using cannabis products responsibly and appropriately. We need to be talking about intake methods. What are the pros and cons of each? Because we may want to utilize a different delivery system depending on the need. So for breakout pain, somebody might really benefit from a vape pen. That gives them immediate relief. But if somebody is looking for sustained pain relief, well, that may not be the best choice for them. They might benefit from something that is longer lasting, such as an oil. We need to be talking about activation times and what somebody can expect with these different routes of administration. What are the components in the plant? We have this enormous alphabet soup in cannabis. So do they know what CBD is? Do they know what THCV, THC, CBG? What do these things mean? What are terpenes? What are polyphenols? What are camflavonoids? There's a lot for people to understand, and we can present it in an easy to understand, simplistic manner. We need to teach people how to read a label. What are the risks? A true assessment of what are the risks and how do we reduce harm. First-time cautions. We should talk about how individual responses vary, and that's based on someone's cannabinoid metabolism and the health of their endocannabinoid system. How do we find informed medical professionals? What is opioid sparing? Can I use cannabis with my opioids? Absolutely you can. And when you do, it actually reduces your risk of addiction, reduces side effects, and it allows you to take a lower dose, making the opiate itself anywhere from 3 to 9.5 times more effective. And we're going to talk about that a little more in the presentation as well. what does somebody do when they're over intoxicated? How do we report serious adverse events? How important is it for people to abstain from driving or operating heavy machinery when they're impaired? And what does impairment even mean? And how do they assess that? Not shame-driven, no, but responsible information so people can make an assessment and then offer some alternatives. Goober, for example. And then I think it's important for people to understand that we should not be mixing cannabis with alcohol or other drugs, that it's not a good scenario. And then for people who want to take a deeper dive, where can they get these resources? Folks who are new to cannabis, would somebody mind shutting this door for me? I have to shut them all, but this hot's a little distracting.
Maybe jump the top.
Thank you very much. So, people who are new to cannabis are going to be thinking, well, what if I don't want to get high? I mean, how many times have we heard that? I don't want to get high. How do I know which products to use? How much should I take? These are all things that we could easily help consumers understand. And consumers would like to have these conversations with their doctors, but very few physicians are actually equipped to have this conversation with their patients. And this is something that we absolutely have to address. So in this peer-reviewed journal article by Ivanov et al., which means everyone else that helped on his research paper, they report that almost 85% of physicians said that they received no education about medical cannabis in medical school. And they don't feel qualified to have this conversation with their patients. In this journal article by Philbrick et al. From 2020, most of their survey respondents, they had 251 family docs, primary docs, said that they got less than 1 hour of education in medical school about cannabis, and most of it was from the substance abuse perspective. In July of 2025, Liz Shearer, who is a fabulous reporter and has done quite a bit of writing on the topic of cannabis, wrote an article for Medscape to take a look at this situation. And she writes, there are 19 cannabis education certificate and or master's levels programs offered in colleges and universities and graduate schools in 14 U.S. states, meaning that only about 1/3 of the 48 states that have legalized medical cannabis have some sort of college or graduate level curriculum to support their patients. And then it goes on to say that more than 1 million practicing physicians in the U.S. and concurrently most future prescribers are without a framework to leverage what has the potential to become one of the most important tools at their disposal. This QR code will take you to that article if you have an interest in reading it. And then last fall, this article came out by Zolotov et al. This is really interesting because this is a group of physicians, pharmacists, and PhDs that are very well informed about cannabis, came together to try to assess what are the core competencies that medical professionals really need to understand. And the end result was physicians and medical professionals should understand the basics of the endocannabinoid system, describe the main components of the cannabis plant and their biological effects. They need to understand the U.S. regulatory framework, be able to describe the evidence base for health conditions that are commonly managed by cannabis, understand the potential risks of medical cannabis use, and to understand basic clinical management with medical cannabis. So this is, I don't want to say a shameless plug, but my business partner is this gentleman here, Dr. Ethan Russo. He is the top medical cannabis professional in the world. And so we have put together a 40-hour online master's program that includes the data that we believe should have been taught in medical school, because physicians need a way. Physicians, nurses, all medical professionals are out there having to dig up the research and figure this out on their own. And the truth is, they don't have the time to do that because medicine is hard and they are drinking from a fire hose all the time. So we have included all of these items you see here in our clinical education, and I'm not going to read these to you, but do I need to go back for you? Okay. So I know sorry, it's also in your program, so there's an advertisement in there. All right, so moving right along, I want to talk a little bit about consumer protections. We must educate and not over-regulate. So what's the first thing somebody's going to do? They're going to look at a label, and this one right here is terrible. 9,000 milligrams of what? It is not listed on there anywhere. Plus, it has a whole bunch of crap in there I'd never put in my body. And nor should anybody who is using cannabis for a medical reason. Now, what is good about this label is that it says that it's lab tested and it was manufactured in a GMP facility. So what does good labeling look like? Well, this, you can see I've circled all the good parts in yellow. Right on the front, it tells you this is a 1-to-1 CBD to CBDA product, that it's 5 milligrams per piece, that it's been lab tested, all the good stuff. And it has a list of all of their ingredients. Then the QR code on the bottom of the product actually goes to the COA, which you see here. These are certificate of analysis that tell you that this product has certain cannabinoids, terpenes, and that it is free from pesticides, mold, biologicals, all the nasty stuff. So this should just be standard and part of our regulation that we have good labeling. This is a simple thing for us to do. You see here, props to our folks at 4K Farms. This is hemp flower, and his QR code also goes to the latest information that you see here. Welcome, gentlemen. Come on in. This is my most favorite COA. COAs are not all created equally. Different labs do them different ways, but this is Phytofacts, and I like it because at the top you see cannabinoids, terpenes, then they present it to you in a visual way. Then here you're figuring out, okay, what is this going to do for me? How might this make me feel relaxed, energized? So this one is going to make somebody feel more energized. Then we've got the flavors and the aroma, and then down here, my favorite part, which terpenes are in it. This is very simple for us to require people to do. Yes, it's going to increase cost, but I think public health is worth the investment. All right, I want to make a quick note about pesticides and why these COAs are so important. In an informal survey in 2014, which I realized was a long time ago, this author, which is my business partner, Dr. Russo, did an investigation that showed that 15 to 35% of samples submitted to California labs were positive for pesticides. That's not good, y'all. And then in another study, it demonstrated that up to 70% of the pesticides actually were spiked into herbal cannabis and captured in the smoke. So keep in mind that we know a lot about cannabis, but what we don't know is what happens when we light flower on fire or vaporize it, and how those pesticides then perform in the human body. So such things are super important. If you are interested in this topic, this QR code will take you to the Oregon website, and we advocate for adopting the Oregon state standards for cannabis because it does address this issue very well. Another important point is that when it comes to vape products, it's important that we not allow vitamin E acetate. That's a dangerous product. Very simple thing for us to put in the rules to protect the public. So there are serious, potentially serious risks with cannabis use, but they're rare. And frankly, I will tell you that they have been overblown. All right, so moving right along, the one that comes up all the time is cannabis use disorder. I know that cannabis use disorder does in fact exist. It is a real thing. And I also question if it is as big a thing as government and anti-cannabis lobby would like for you to believe. So how do we assess cannabis use disorder? And I prefer that over CUD. That just doesn't sound good, does it? All right, so we have the Diagnostic and Statistical Manual of Mental Disorders, so that's DSM-5, and basically it's defined as problematic pattern of cannabis use leading to clinically significant impairment or distress. So a person has to only have 2 of the 11 things listed on this slide to, in the past year, to then be qualified as having cannabis use disorder. You see it over here. We have different levels of severity. So it goes up from mild, moderate to severe. And, this is an old list. And if we go back to total prohibition, please know that number 3, a great deal of time is spent obtaining, using, or recovering from cannabis. How much time are people going to be spending to get the product they want? As we saw in one of our earlier slides, cannabis use isn't going to decline. Where people get their product, however, is going to shift from the legal to the traditional market. And so I have a lot of questions about how we're assessing cannabis use disorder. So let's look at some government statistics, and stick with me because we're going to do a little math in our next slide. So according to the Substance Abuse and Mental Health Services Treatment Episode Data Set, which comes from SAMHSA, in 2020, there were 139,481 admissions to treatment centers for marijuana or cannabis-only treatment, out of the 1.4 million people that went to treatment centers in general. So by comparison, in 2010, that number was 358,000 plus. And let's think about why the difference in the number. Well, I'm going to argue that it's because we had big advancements in our medical cannabis laws, and there was less prosecution of people who are in possession of cannabis. In 2015, 50% of the people who were in treatment for cannabis were there through court mandate. They had a choice. They could go to jail or they could go to treatment. Well, I'm pretty sure the beds and the food are better in treatment. All right, so let's do some math. And I'll ask you, does it add up? So when we take the CDC at their word, they say that 3 in 10 people are going to qualify for cannabis use disorder. That's 30%. So of the 44, if we're using the 44 million number of regular cannabis users, then 30% of that is 13.2 million people. So SAMHSA says that only 16.5% of people who qualify for cannabis use disorder get treatment. So of the 13 million people who apparently have cannabis use disorder, if only 16.5% of them are getting treatment, that's 2.17 million people. But the report from 2020 said that only 139,481 people got treatment. So does that add up for you? So I love the phrase, the math ain't mathin'. So I'm skeptical. So one thing that we hear from lawmakers is their deep concern about addiction. And yes, cannabis can be addictive for certain people, but it is not addictive in the same way that other drugs are addictive. And we're going to take a deeper look at that here in a moment. So this slide comes from an article from the New York Times in 1994. I get it. It is an old slide, but the data has not changed. And you can see here that cannabis has a lower addiction potential than caffeine. But I'm not seeing anyone try to outlaw caffeine. Go ahead.
The vertical axis, is that percentage or what? Like there's only one, or is it 1 in 100,000? I'm sure it's...
You know what? That's a great question. I'll have to go back and dig this up and get back to you. We're going to look at it in different ways. Yeah. Thank you for the question, though. So I wanted to know, has that really changed from 1994? And I went to a variety of peer-reviewed journal articles, and I pulled some information about this topic, and then I put all of those articles into AI to help me build this table. And what is important, in my opinion, about this is that cannabis still is at the very bottom of the list here. And even through these journal articles, which were actually mostly written from a substance abuse perspective, still indicate that cannabis has a very low to moderate, which I would argue, addiction potential. Look at dependence severity, very low. Cannabis is lower than caffeine. And then when we think about withdrawal symptoms, they're mild. Irritability, people might not be able to sleep, but that resolves itself in approximately 28 days. All right, so we're going to shift gears. Let's talk about cannabinoid hyperemesis syndrome. How many of you in here have heard of this? All right, you guys are super well informed. So CHS is a rare but increasingly recognized condition with some very perplexing symptoms. It includes nausea, vomiting, severe abdominal pain, and the most interesting thing about it is that the majority of people with CHS have this very strange bathing behavior where they take very hot showers, so hot that many of them will get third-degree burns. This is a serious condition. So CHS is triggered by heavy and chronic exposure to THC. And the only way to stop it is to stop using cannabis. So my business partner and I, along with a couple of other investigators, did a study in 2021. My business partner, Dr. Ethan Russo, hypothesized that this condition is probably genetically related. And so before we get into what we learned in our research, I want to share that CHS comes in different phases. Those phases are the prodromal phase, where somebody might have something akin to morning sickness, anxiety, hot flashes or the sweats. And then they get into the hyperemetic phase, and that's when they have that severe abdominal pain, nausea, vomiting, and the compulsive hot bathing behavior. And then when they go into recovery, that's when they are fully abstaining, not even taking a pure CBD isolate. They have to abstain completely from all cannabis exposure. And it may take a year for those symptoms to go away. And then for most people, when they start using cannabis again, they will start to experience these symptoms. Research about statistics, I should say, about prevalence of CHS are all over the map. One of the challenges that we've had was that there wasn't an international classification of disease code. And this year we got one. So it's ICD-10 code is R11.16. And I think we are going to see over-reporting of CHS for a little bit, because a lot of people are going to think that maybe cyclic vomiting or other nausea and vomiting related issues are CHS. And I think it's going to take a while for us to sort of figure out really what is the true prevalence. So just a quick summary of what we learned. I'm not going to read through all of this, but about 16% of our research population actually had a diagnosis of cannabis dependency or addiction. This particular population is genetically predisposed to addiction. And let me go back real quick. So 100% of our population had used cannabis in the last year. 70% of them were using daily. And we had age-matched controls that also had the same cannabis usage patterns as our study participants. And they were using around 4 grams of flower a day, which is a lot. So in this slide, it shows that we found 5 gene mutations to significantly increase an individual's susceptibility to CHS. And this is a very small study. We had 28 participants, and of the 28 who had a confirmed CHS diagnosis, we had only one person who had one of these. We had multiple who had 2, several who had 3, some who had 4, and a small handful of people who did not win the genetic lottery and had 5. So one of the things that we want to understand in the future is, what do those gene combinations mean to the experience of that individual who is having CHS? So we don't really have time for me to go through these, but just to say that these different gene mutations do give us tremendous insight as to why a person has CHS and why they have addictive behaviors. In this population, they have a lot of psychological, psychiatric issues. They're a difficult population to treat because they do not believe that cannabis is what is causing their illness. So as a way to improve public health and safety, we created a website. It's whatischs.com. Our research, a lot of presentations about this, a ton of information and support groups are on this website, and the QR code should get you there. Next, I want to talk about psychosis and schizophrenia. So the thing we hear from so many people at the Capitol is, well, cannabis causes schizophrenia. That is not true. There is a link between cannabis use and schizophrenia, but there is no causal evidence. And what we see in the schizophrenic population, or people who are genetically predisposed, is that many of them are using THC as an attempt to self-treat. And it is true that people who have schizophrenia in their family or are otherwise genetically predisposed should abstain from THC use unless they are doing so under the care of a physician. We have seen several randomized clinical control trials in this population have shown that CBD is actually very beneficial to managing schizophrenic symptoms. So this is a 2004 slide. This data has not changed. Cannabis use, this is McLeod et al., and cannabis use appears to have increased substantially amongst young people over the past 30 years from around 10% reporting ever use in 69 and 70 to around 50% reporting ever use in 2001. This population was from Britain and Sweden, and it states, if the relation between use and schizophrenia were truly causal, and if the relative risk was around 5-fold, then the incidence of schizophrenia should have more than doubled since 1970. It has not. It has remained stable. There's some evidence that it has slightly decreased. So that whole schizophrenia, the sky is falling thing, doesn't really hold water. There are multiple studies that confirm this. We're not gonna get into them because I want to give you guys a few minutes to ask some questions. This is from the GW Pharmaceuticals study, Sellers et al. From 2013. When we look at Marinol, which is pure synthetic THC, versus Sativex, which is a whole plant cannabis pharmaceutical drug that is available in many countries outside of this one, you can see that the safe dosage range is significantly greater in the 1-to-1 on the THC CBD product than it is with straight THC. So this is part of what we need to be educating people about, is that that they don't want to take too much THC.
That's a pretty low dose of THC.
So this is the dose would be about 18 milligrams. And as we're going to see here in just a little bit, typically we don't see psychosis in balanced whole plant cannabis products in the 10 to 15% range. That is very, very low. Psychosis, typically, psychotic episodes are typically driven by much greater THC content. All right, so I'm gonna keep going. This is interesting. McGuire et al. In 2018 showed that in the schizophrenia population, the highest rate of the adverse events are actually in the placebo group.
Okay.
And that has been reported consistently in the literature. In this same article, they showed that both patients and physicians showed that they were significantly improved using CBD. So I have to confess, at the last legislative session, I was like, we have to ban synthetic cannabinoids. And yesterday, I was on the panel with 3 people talking about the fact that what really matters is purity. And the reason I was saying that we shouldn't ban the synthetic cannabinoids is because we hadn't got to the purity conversation. And the synthetics that have been on the Texas market, frankly, I'm scared of them because they have no checks and balances on their safety, purity, and quality of the product. And it's all the other things, the byproducts of making that chemical component that concern me. And so if we can get to a regulatory framework that requires purity and quality, well, then I will feel very differently about synthetic cannabinoids. So I just want to point out the nuance here that, let's see, third from the bottom. the synthetics are, many of them, not all of them, have stronger binding affinity to cannabinoid receptors. And so if somebody typically has been taking a 5 milligram gummy of THC, botanically derived THC, and they have a synthetic product, that could actually be 10 milligrams or 500 milligrams. And so that's where we start to get into trouble, is when people are taking products that weren't made safely, and they're taking too much of whatever it is that's providing a psychoactive effect. This is about suicidal ideation, and what's interesting about this slide is that in this research done in 2024, suicidal ideation dropped several points from 23.6 to 17.6 in this research population over 3 months. All right, so other possible side effects, you can see them all here. I'm going to keep going. Adverse event reporting is super important. I don't think that we have necessarily the best possible reporting mechanism currently, and having a simple hotline where people can share information would be great. I do want to point out, and we've had so many conversations about the children. Our packaging should not appeal to kids. We shouldn't have cartoons. We don't need to have celebrity endorsements on the face of something. And then we have age gating. These are simple solutions. And I also want to share that for kids under 10, they are less likely to be impacted from overconsumption because their bodies aren't yet processing cannabinoids in the same way.
Okay.
All right. So I'm a proponent for people being able to use THC. It demonstrates broad spectrum therapeutic effects for over 70 health outcomes. It is effective in treating cancer symptoms. It has a favorable safety profile, and it is truly versatile, addressing a wide variety of neurological, gastrointestinal, viral, and psychotic conditions. All right, here are some positive side benefits. How many products do you know that actually come with those? We certainly aren't seeing that in the pharmaceutical world. All right, so quickly, I wanted to mention food for thought, that in states that have a well-functioning cannabis law, we see healthcare spending go down. I had to go into the Wayback Machine to get this slide, and I wasn't able to get access to these two articles because they're behind a paywall. But if you can imagine what these numbers would look like in today's data. So this study from Bradford and Bradford from 2016 shows that from 2010 to 2013, doctors in states that have a functioning medical cannabis law wrote 1,862 less daily pain dose prescriptions. So that generated a savings to the Medicare Part D prescription spending of about $104 million in 2010 and $165 million in 2013. So if we extrapolate that data to look at all states to adopt, if all states had adopted an MMJ law, that would have been a decrease in nearly $500 million in Medicare Part D spending. That's just for pain medicine. So you can imagine, what does that figure look like for all prescriptions? So Oops, wrong one. Sorry. Oh, no. Help. There we go. So what would happen if we actually had data on how the current state of the hemp and the medical cannabis industry is impacting our healthcare spending, and how is that impacting public health? And I think that we would see some mind-blowingly positive results. So I want to leave you guys with this. Cannabis is the single most versatile herbal remedy and the most useful plant on earth. No other single plant contains as wide a range of medically active herbal constituents. So it is incumbent upon us to improve public health by not approaching this topic from a substance abuse and law enforcement perspective, to provide safe, legal access to all forms of cannabis for adults. And yes, that includes flower. We must educate consumers, and that includes being honest with teens, because when they are informed with data that isn't driven by judgment, they are going to make better and more responsible decisions. The same is true for everyone. We must educate medical professionals. We must educate consumer-facing industry, law enforcement, lawmakers, regulators, and we have to enforce our consumer safety laws. So with that, I thank you for your attention, and I'd love to have a few questions if you have some. Yes, sir.
Yeah, I'm curious what you know about the onset of CHS when it comes to high THC content and the big.
All right, so the question is, what do I know about the onset of CHS when it comes to high THC content in vapes? Was there any more to that?
Well, yeah, I'm only bringing up the vapes just because I know since they are a liquid, you can have way more THC as compared to flower. And so I'm just curious to see if we have any.
So in our data, it wasn't about vapes versus flower or any other form factor. It was about amount of THC and how much people are consuming. So the high THC vapes for people who are genetically predisposed to CHS are not good for them. And anybody who is genetically predisposed to this should avoid high THC anything. Yes, Karen, I'm sorry. CHS is cannabinoid hyperemesis syndrome. I know what that is, yes. Yes, Eric. Thank you, Karen.
Hey, Misha, thank you for all the good work you and Ethan are doing. I actually have two questions on the biological side. For CHS, where are you seeing onset? Are you seeing for folks who are genetically predisposed onset, like pre-clicks after they use cannabis or after years of use? And the second is the 10-year-olds and under. Can you explain a little bit about the biology and why cannabis is not impacting them and why the risks may be lower? And I know there's all these other things, but I thought a two-bird, you're aligned.
All right, thank you for the question. So let's address kids first. So the question is, why are kids under the age of 10 not as susceptible to cannabis intoxication as adults? And that's about the maturity of their endocannabinoid system. And then the second question, tell me the first question.
Is CHS, identify
that's right.
the genetic predisposition, but
Yes.
where are you seeing onset?
All right, so that's an excellent question. And it's one that we want to do more investigation on because, frankly, it's all over the map. So CHS, cannabinoid hyperemesis syndrome, is indicating that there are a wide variety of experiences in this patient population. And we have people that showed up in our survey that have been using cannabis for 10 years. And sometimes CHS came about because they changed form factor. Maybe they went from flower to concentrates, or maybe their usage patterns changed. Then we had other people who might have been using low dose products, and they had done so for a short period of time, maybe a year, and then they got CHS. And then we have some that got it just within a couple of months of starting to use cannabis. It is really all over the map, and so we haven't yet been able to establish a pattern.
So just a quick follow-up question. I remember there are some, like Len May is developing a kit that did genetic testing that is looked at that guide cannabis use. How easy is there to be genetic testing to show that you're predisposed to that? I'm trying to come at like as a public safety issue and having those linearly solved.
All right, so for those of you watching, Eric's question is about how can somebody test if they have this. Our company has a patent pending on this genetic test, and in the spirit of full disclosure, Lynn May was part of the research team. Our company licensed this to them, and we are no longer in partnership with them, and we'll be licensing this to another entity, and it should be commercially available sometime in the spring. And it is a simple cheek swab.
Thank you. And I need to get it. They have commercial business. I just started rapid.
Well, I think, it may show up another genetic test.
Yeah, that's awesome. Thank you.
Yeah.
Just to follow up on that, many times in medicine we don't have a good test, but a therapeutic withdrawal and resolution of the disease and recurrence with re-challenge kind of tells you what's going on as well.
Yes.
But Mike, thank you for the great talk on education and public health, because I think that's the theme of it, right? Education is the key to improve public health.
Sure.
Well, this last year has certainly taught me a different lesson, which is miseducation, misinformation locks the public into a poor health stats. You know, especially if we depend on just government entities like the CDC hearing.
Yes.
So people aren't going to go to Credo and get their information.
They are not.
So what's your, game plan?
Okay, so the question is about where can people get access to information about cannabis, and you're saying that education is key. We're singing the same song. So I would love for there to be a public education campaign. That was one of the things that I was saying at the beginning of my my talk, is that we need this repository of basic, clear, straightforward data for all people. I would love to see there to be public education campaigns at the point of sale. We need it for everyone. And the more people who have a basic understanding of how and why components of the cannabis plant work in the human body, the better off we are going to be. And so it's kind of an all-points effort. Manufacturers need to get on the education train. I'd like to see government. I'd like to see education in schools. I'd like to see some billboards. It would be great if there could be a QR code printed on the receipt of every single product that is sold. It's a simple way to get people information. It's not that hard. We are not talking about rocket science. All right. Well, we are out of time. I thank you all for your time and attention, and really appreciate you coming to this conference and all the work that you guys are out there doing. I know we're all on the same team. Thank you.
Thanks.
Thank you. Good to know. Well, they think you're the best. You're very decent. I love your slides.
Thank you.
You need to outreach to